doctor, I have a patient, 8 years old boy lah, with underlying steroid-resistant nephrotic syndrome. Okay, patient is on cyclosporine, enalapril, and atorvastatin. Last relapse was in May. So currently presented with abdominal distension for 1 week with facial puffiness for the past 2 days. And then he also came in with frothy urine and reduced urine output for the past 1 week. Otherwise, previously, patient was had URTI symptoms lah, fever for 1 day and cough and runniness for 1 week. The sick contact was actually he went for a family wedding and the whole family got sick. Otherwise, no abdominal pain, no vomiting, no leg pain, no bone pain, no rashes, no hematuria. Okay, then on examination, the patient is alert, conscious, CRT less than 2 seconds, good pulse volume lah, warm peripheries. Then you can see some periorbital swelling and facial puffiness. Lungs is reduced air entry on the right side, on the lower zone. CVS, dual rhythm, no murmur. Per abdomen soft, distended. Then there is a presence of ascites lah, fluid trails and shifting downwards present. And then at the lower limbs, there's there's swelling lah over the thighs. Yeah.
Okay. So that one admission, the relapse because of what?
Because of the URTI symptoms.
URTI.
Yeah.
Okay. Alright. So why he was labeled steroid resistant?
Because they actually had at first they said that he's steroid sensitive lah, and then he kept taking the medication, but then every time they come to the clinic, he still gets relapses, frequent admission for relapses also. Then eventually they thought that maybe he's not compliant also lah to the medication. Then finally they tried cyclophosphamide. But then based on the values in the readings, is very like up down lah. The levels is not consistent, so maybe there's issues with compliance. Then they also did a biopsy. Then they noticed that there's minimal change disease, and then eventually they started him on cyclosporine.
Okay. So when they label the steroid resistant? Don't know.
Not sure.
Since when? Not sure.
Yeah.
So
I think 2022.
alright. So by definition, what is steroid resistant?
Steroid resistant means within by right the definition is within the first 4 weeks of induction, it cannot achieve remission.
So what is remission?
Remission is urine protein nil or trace within 3 consecutive days.
Okay. So relapse definition?
Relapse is urine protein more than 3 plus for 3 consecutive days. Yeah.
3 plus.
Yeah, the old definition is 2 plus, but then now there's a new definition which is 3 plus.
Alright. Okay. So he was frequent relapser before?
Yeah, frequent relapser.
So frequent relapser, what does it mean?
Frequent relapser is basically within 6 months of initiation of treatment, there's at least 2 relapses.
Alright. So the other definition?
It's 3 relapses within 1 year.
3.
Yeah. 3.
Is it the new definition?
Yeah, I saw
Are you sure?
Fitz protocol.
The latest one? 5th one? Okay, that's fine. I haven't read the 5th one. Okay lah, the old one is 4.
It's 4, right? Yeah.
Okay, so the new one said 3 already
Yeah.
lah. Alright. Okay, so if that one is steroid sensitive, what does it mean?
If steroid sensitive, then it's able to get remission within the first 28 days of induction.
Okay. Steroid dependent?
Steroid dependent is relapse within the treatment.
To relapse within the treatment.
Yeah, within treatment or like within 14 days of when they stop, they relapse.
Okay, alright. Okay, so how you diagnose nephrotic syndrome in the first place?
There is 4 criteria. One is the proteinuria of more than 3.5 gram over 24 hours, or urine PCR more than 200. And then there's hypoalbuminemia of less than 30, and then peripheral edema, and also
Peripheral only.
generalized edema.
Okay.
Proteinuria and hyperlipidemia.
Okay. Alright. So what investigation we send during the initial
stages, we send the routine blood investigation lah, FBC, RT, LFT, coag profile. Then we also send like specific investigations like the SOT, the anti-streptolysin O, titers C3, C4.
Why we send that?
The SOT we send because it can also be a group B group A. Beta hemolyticus streptococci.
So post-strep.
Post-strep glomerulonephritis.
Okay. So why we send C3, C4 as well?
Because in the post-strep, the C3 can decrease, means they are using it a lot, or in SLE also they use it, C3 and C4.
Okay. So basically to rule out other nephrotic causes lah, or secondary causes. Alright. So primary causes of nephrotic in children?
Minimal change.
So if you do the biopsy on electron microscopy, what do you see?
Don't really see anything much, but the podocyte.
On that one on normal microscope.
Then the podocyte, there's a loss of the podocyte.
Okay, so you remember what I said. Okay, so once you confirm the diagnosis, how do you treat?
We give the induction lah. We start the induction with prednisolone, 60 mg per body meter square OD.
So how you count the BSA?
Weight times height divided by 3,600 square root.
Okay. So how long you give the induction for?
Based on new guidelines, is 6 weeks.
Okay.
Previously it was 4 to 6 weeks.
Alright. So until achieve remission lah. It doesn't have to be 4 to 6 weeks lah. Okay. So next, after you finish patient achieve remission, what do you do?
Then we continue with the EOD. Some guidelines say no need, but
so now the latest guidelines say what?
Based on the 5th protocol, the 5th one is EOD lah, prednisolone 40 mg.
So during induction one, the first one initial treatment, we still give 6 weeks. The first one.
Based on the guidelines, is
4 weeks or 6 weeks?
They say 6 weeks.
6 weeks now.
Yeah,
Okay,
now
fine.
it's 6 weeks.
Alright. Okay. So doesn't matter lah if you achieve remission or not, you still keep at the same also like it was 4 weeks before, then now probably they said 6 weeks, then we go 6 weeks lah. Alright, then you change to EOD. So the EOD induction dose is what? Maintenance dose is how much?
40 mg.
40 mg per?
Body meter square. OD.
OD or EOD?
EOD.
EOD. Okay. So during the complication of nephrotic is what?
Complications complications is like thrombosis, thrombosis or infection like peritonitis.
So you remember why they got thrombosis?
Because when the protein leaks out, the clotting factors also leak out.
What protein factors?
Protein S, protein C,
Okay. Alright. Okay. Other complication?
Infections, because the immunoglobulin also leak out.
So what infection they can get?
URTIs.
The worst one?
The worst one is spontaneous bacterial peritonitis.
Okay, so if you got SBP, what are the symptoms?
Severe abdominal pain,
some more?
nausea, vomiting,
Some more?
fever, very high grade fever.
Some more? When you have peritonitis, what symptom else do you have other than what you have mentioned? Diarrhea can or not?
Sorry?
Diarrhea?
Diarrhea, yeah, can.
Can lah.
Change in the bowel habit.
Diarrhea, you irritate the bowel, then you probably have diarrhea as well. Okay, so antibiotic, usually we start what? Cover for peritonitis?
Penicillin V.
That one is prophylaxis.
Okay.
Okay, so for peritonitis, for antibiotic, you should start.
Augmentin?
No, not enough.
Not a plus.
Not enough.
Ceftriaxone?
Yeah, something along that one, but not specifically ceftriaxone.
Cefotaxime.
Cefotaxime lah, usually covers probably better coverage for gram neck.
okay.
Okay, ceftriaxone also fine, but I think
Cefotaxime is better lah.
the antibiotic of choice is cefotaxime lah. I think I don't know lah if the new guidelines say what lah, but most of the time just cefotaxime. Alright, so if you're talking about prophylaxis just now, pen V, so how long we give?
About 1 week.
1 week,
Not sure. 14 days.
10 days lah usually. 10 days just to cover for the all the strap or whatever, usually 10 days treatment. Okay. So steroid, what are the things that you need to watch out for?
The complications of steroids like normal complications that they can get is like the moon face, the buffalo hump, the thin skin. We need to also stand for eye assessment because they can get the steroid induced cataract or glaucoma.
Okay. Sama.
Then
Every system there is something.
Pleuritis.
Okay. Lagi bit more, the one more common was
Edema.
edema can. They have water retention lah. Alright,
Yeah.
sama.
Then we can also give like PPI because sometimes they can get the ulcer, peptic ulcer lah.
Okay.
Yeah.
What else? Infection?
Oh
Hematology?
yeah, infection. Like one of the most common things is infection lah, because they are immunosuppressed.
Okay. The endocrine?
Endocrine, they can get acute adrenal crisis.
Okay.
Yeah.
Because prolonged suppression. Sama. Lagi endocrine complication, steroid.
The
A lot of endocrine.
infertility.
Fertility,
Not really lah.
nothing. Alright, next. Cyclophosphamide, yes. Not really steroid.
Yeah.
What else? Endocrine? If you think about endocrine, what is the most common disease under endocrine?
Cushing syndrome.
Okay, sama.
Cushing's disease.
Not just Cushing lah. Apa lagi more common endocrine in Malaysia?
Oh, diabetes.
What?
Diabetes.
How can get diabetic?
Because there's increased glucose in the body. So
Yeah, it's a stress hormone, right? So you
diabetes.
akan increase your glucose punya formation and everything lah. So other than endocrine, what else? Other than diabetic, what else they can get? Cushing also they have what? Cushing symptom apa?
The moon face, all that.
Okay, apa lagi spesifik yang you haven't mentioned?
Chocolate obesity.
Okay,
Weight gain.
Okay, sama.
Mood behavior.
Okay, sama.
Depression, anxiety.
BP? What about BP?
Or hypertension.
Okay. What about musculoskeletal?
Weak.
Weak what?
Peripheral myopathy.
Okay, sama.
Osteoporosis.
Okay, sama. Anything about the bone other than osteoporosis? About the head of the femur? What can happen?
Compression fracture.
Okay, possible.
Osteoarthritis.
Head of the femur?
Osteoarthritis.
Okay, lagi head of the femur, what can happen?
Necrosis.
Avascular?
Avascular necrosis.
Can happen, right? Can?
Yeah,
Cannot?
yeah.
Alright. Apa lagi? The crime. Okay lah, I think roughly that cover most of it lah. Okay. So, if patient come in shock, nephrotic syndrome, why do they come in shock?
Because in nephrotic syndrome, the albumin will go out right of the cell, so they actually reduce volume because it actually goes out in the cell. So peripheral, in the intravascular.
So what kind of shock is that?
Hypovolemic shock.
Hypovolemic shock. So how do you want to how to manage the patient come in shock?
We can give bolus.
What bolus?
IV drip normal saline.
Are you sure? You want to give normal saline? Patient problem nephrotic what? If you give normal saline, what happen in nephrotic syndrome?
Get hyperuricemia.
No, not necessarily. Patient already low albumin.
Oh, okay.
And then where does the fluid goes to?
It
Hypoalbuminemia.
will go out.
Go where?
Go through the kidney.
Go to the tissues.
Oh.
You cause more edema.
Okay, then
So what's more appropriate?
D5.
No.
Oxide 95.
No. What's more appropriate? It seems they're losing albumin. So why you need to replace it with?
We give albumin.
Yeah, give albumin.
Albumin.
It doesn't matter lah. You can give albumin 5% ke 20% ke.
Okay.
Probably something albumin along albumin punya ni lah. Alright. So you give normal saline, it will leak out. It cause more edema. So it doesn't work. Okay. Alright. Okay. So apa boleh make sure. Alright. Okay, for let's say patient already on induction, you already treat edema gets better, haven't achieved remission, so okay, specialist said can probably plan to go back within the next few days. So what you basically must do to prepare parent and patient for them to go back.
Advice lah.
Okay, so what advice?
We have to like tell them that this is a lifelong disease, so they have to like monitor at home. So basically they have to like know how to measure the urine dipstick also lah. If 3+ for 3 consecutive days, they have to come in. Then they also have to.
So what about the dipstick?
They have to monitor like.
No. What about the dipstick that you have to counsel them?
Or like how to use it.
Okay.
So basically we ask them to pee, then you take the thing and put inside the strip, and then based on the strip we look at the bottle lah, then we see the color.
Okay, so you need to teach them about that lah, how to interpret. Okay, so other than doing that thing, then they said baca 2+, what else they need to do? If or after they read the dipstick?
If every day for 3 consecutively have to come in.
Okay, so how do you ask them to keep the record?
A diary.
Diary lah. So you need to ask them to
keep
buy a books lah. Okay, usually what books we ask them to do?
The small
the hard cover kind of thing lah, so that it's longer, easier, better to keep, so that they tak rosak for a long time. Okay, so other than ask them to prepare the dipstick, ask them to teach as well. Okay, what else?
Then we have to ask them to make sure that they are compliant to the medication. Make sure they take the steroid every day. Then if let's say they have edema, even though the urine dipstick is nil, they still have to come in lah. Yeah. And then low salt diet when got edema, otherwise a normal calorie diet. Then they also have to make sure that they watch out got any chicken pox, like any exposure to chicken pox. Then if they are exposed, the child has to take the oral acyclovir. Yeah. Or immunoglobulin.
Alright.
Yeah.
What are the more important advice to tell parents?
The monitor for the complications.
Okay. What complication that we are worried about?
The thrombosis.
Some more?
And the peritonitis.
Okay, the infection lah.
Yeah,
so
infection. So if they have like abdominal pain
so
or
what do they
fever,
have?
they have to come in.
Come in immediately lah. So don't wait. Okay. Lagi I want to ask. Let me think. Okay, so how do we prevent infection patient kalau already this patient on nephrotic syndrome? Ada advice we can ask them to
avoid crowded areas.
Okay, sama?
Make sure they wear a mask. Kalau if they go for any family function.
Okay, any vaccination you can ask them to take?
Yeah, we can avoid live vaccination when they're on steroid treatment. Otherwise, they need the pneumococcal and the measles vaccine.
Okay. So when patient come for follow up, what do we assess them?
Assess like the clinical features.
Features
for any edema.
Okay. Sama?
Then any like steroid toxicity, so we can like monitor the symptoms. I mean the signs. Check the book for the whether they monitor properly or not every day they are doing or not the urine dipstick.
So what more important thing also we want to assess?
For the complications.
This complication you haven't mentioned yet, but we can assess them during follow up as well. Certainly after many months you can see it can affect this thing also.
The hypertension.
Okay, no, it's possible, but you mentioned that already. There's one thing you haven't mentioned. I think it's quite important.
The frothy urine.
No, it's nothing about the urine one. It's probably something to do with the endocrine. If you see pediatric patient, the normal routine one, we always assess one every day, every single patient. What the nurse will check, then you will need to review lah. For all pediatric patient, they must have what parameters.
Normally it's the vital signs.
Okay, other than vital sign? Adult we don't ask lah. Pediatric for sure
Oh,
we
the
ask one.
bowel lah.
No, not bowel. What are the pediatric parameters other than vital sign? You need to plot one.
Oh, the growth chart.
Of course,
The
growth.
weight and height.
Yes,
Yeah.
the weight and height.
Oh,
So
because if got what is that? If there's fluid overload, then the dry weight is like the weight will
okay,
increase.
that's not just the only
and then
reason.
the steroid can cause what growth delay.
Growth defect
Yeah,
lah. Can cause
development delay.
can cause stunting lah. Alright.
Mm.
So you need to do the monitoring lah. So must plot the
Growth
growth chart. Okay. Growth chart is somewhat doesn't sound very important, but it is very important lah,
Yeah,
because you don't do it, you won't detect the problem. Okay, unless memang you see the child small, probably you will do it lah. But the mild one, the subclinical one, sometimes you can miss lah if you don't do. Then you probably growing along for example 50th centile, then probably it goes to 25th centile. Patient already on steroid. So that kind of thing, the early one you probably won't catch. Okay, so and then this is basically the reason lah some of the masters students fail, because they don't do the basic thing right. They don't plot the growth chart.
Okay. Yeah.
Sounds so simple, but it's very important.
Yeah.
Okay.